and we're doing SPECT imaging, this is what we're looking at. Okay? So all of these would look the same. But again, depending upon which agent you're using, that's going to determine what it is that you're seeing. Now, if we're looking at perfusion, does perfusion necessarily tell me if the myocardium is in good condition or if it's still alive?
What was the question?
Whether or not it's viable.
Yeah, this is the question. Okay, you have a patient that comes in. Does perfusion tell you if the myocardial tissue is viable? No, it doesn't. It just shows you how much blood is going to that area there. There's a law that talks about the percentage of blood going to an area of the heart is removed from the blood, and so we can actually quantitate the amount of perfusion, but it doesn't tell you if the myocardium is alive or not. So in that situation, what other radiopharmaceuticals could you use?
Label. Blood label.
Well, remember, your metabolic agents. Your perfusion agents are not going to help you. Okay, so if you're using sestamib or thallium, that's not going to tell you if it's viable. Okay, it's just going to tell you if there's blood going to that area. Okay, so if you use any of the fatty acids, like the palmic acids, or if you... Now, FDG is not one of your better radiopharmaceuticals, is it? Why is that?
Higher dosimetry.
Well, the dosimetry, but does the heart normally utilize glucose?
No.
Yeah, it doesn't. So unless the patient's received insulin or else there's no fatty acids available for the heart to metabolize, that's not a good agent. Okay, so you need to kind of keep that in mind for that. But as far as the anatomy goes, okay, this is what you're going to be expected to know on your exam is what the different anatomy is for the short axis, horizontal long axis, and the vertical long axis. Okay. And on the exam that I'm going to be giving you probably next week, you'll be expected to know that. Okay. I sent you a copy of one of the tests that I gave a long time ago.
Mm-hmm.
It's about 165 questions.
You didn't say the answer.
Oh, answers. You know, back in the old days when I was a student, we had to look up the answers, but yeah, but I mean, you know, hey, this is the 90s, the thousands or something. But anyway, so on the board or on my test, I'm not a very good drawer, so you may see my renderings like this. So this is what you might expect to see if I'm not able to get good pictures for you. Okay. Oh, the answers? Well, the answers are actually in the handout, so you may actually have to read the handout to answer the questions. Yeah, don't you hate that? I like it better when they just give me the answers. And
Of course, spoon feed.
I could send it to us like Tuesday to verify that we got the correct answer.
yeah. Well, you know, obviously it's usually better if you look up this material yourself because then you actually have to read the material. But as I said, one of the highlights or one of the things that you need to be paying attention to, though, is the anatomy. I don't know if we should really stress a lot of it right now because most of you are pretty comfortable with it. You know, if we were to, like, take a look at the, let's take a look at a patient study here. Okay, here we got a patient. Here's the stress, here's the rest. What do you guys see there?
Ischemia.
Ischemia and
Where? In what part?
apical.
The horizontal.
Okay, well, let's see here. Okay, what's this region over here? Okay, here's the septum, and then what's this region down here, you said?
Inferior wall.
Inferior wall, or apex? Inferior wall here. Okay, and does it fill in?
Yeah.
So on stress, it's bad. On resting, it's good. So you said ischemia. Okay, very, very consistent for ischemia. Okay. Same thing here. We're talking about the apex. Okay. So on this one here, you see that the apex has poor perfusion. On rest, it fills in. Okay, so we know the septum and the apex are not good on this person here. Okay. Vertical long axis, same thing. Okay. Apex doesn't fill in. Now, which arteries would be involved in that? Because remember we talked about the coronary arteries, so which arteries would be in there? Well, let's see here. Here's on my handout that I gave you. Again, this is probably a composite. You know, depending upon what way you're looking at the heart, this would be an anterior view. So we would expect the right coronary artery over here, and there may or may not be a marginal branch here that goes along on that. Usually, the left coronary artery is the one that's more serious when it's blocked. I mean, actually, either one of these is fairly serious, but on this one here, so you have the left main, and then on number 2 here, they may call this a left diagonal artery, and then from that you have the left anterior descending coming down. Okay. And then on number 5 over here, the marginal artery, and then the circumflex. So if you were looking at a part of the heart that is not perfusing, and in this case here we have the septum and the inferior wall, I mean the septum and the apex. So what blood vessels do you think are involved with that?
So for the apex, it would be the LAD, or even further up, like the left main.
Well, in one of the handouts that I sent you for the nuclear cardiac imaging, remember I told you that you're going to see your images either with the bullseye or the polar imaging, or in this case here, it's talking about what blood vessels would be affected. So if we're talking about the septum, you may be talking about the left anterior descending and also the right coronary artery. Usually septum is right coronary artery. Okay. For the apex, okay, right coronary artery and circumflex. Okay. So now you have an idea of which blood vessels may be involved. Okay. This is in chapter 10 of those books that I sent you. Okay. And the patterns, okay, on your board exams, they're typically going to give you, patterns. And again, so here you have a typical polar pattern with the coronary artery region superimposed over it. So in this patient here, okay, stress, we don't see any defects. Rest, we don't see any defects. So what would you call this one? Okay, that's a normal study. Okay.
What's that black area on the rest there?
Remember I told you that when you guys acquire studies, sometimes you'll exceed the number of counts that are in a pixel. And if you do, it resets it back to 0. Okay? So either there's no counts present, or these counts were overloaded. Okay? And like in this case down here, okay, so you have an area, massive area here, so we have quite a few blood vessels involved here. Left anterior descending, and what else do we have involved there? Circumflex, so circumflex, left anterior descending, right coronary artery looks okay, but it fills in. Okay, so I'll have our expert on myocardial ischemia tell us what is wrong with this patient. So, and then the other one that we talked about, a defect on both. Which artery is most affected on this patient?
Right coronary artery.
Okay, the right coronary artery. So mainly the inferior wall, and so both on stress and rest, there's the defect, so you have definite myocardial infarction. Without doing this, well, I guess if you just did the resting images and you saw that there was a perfusion defect, that would be a fairly informative picture, wouldn't it? Because it would tell you that if they're not getting perfusion on the rest, more than likely that area is infarcted. The other thing that I wanted you to remember is that normally on these polar images, you're basically taking your short axis view and making 17 images out of it, or anywhere usually between 12 and 13, up to maybe 17 images. And so basically this is how you're slicing it, and this is how it's represented on the polar image. Now the other thing that I wanted you to pay attention to, and this is in chapter 24, recognizing some of the major changes in EKG patterns. Okay, last week we talked about what we're actually looking at with an EKG. Okay, so you'll basically see things like this on your board exam. When we were talking about the P wave, what was this? What's happening here in the P wave? Okay, atrial depolarization. And remember when we were talking about depolarization, what's actually happening in the heart muscle? Mr. Andy.
What was that?
What's happening when the heart depolarizes?
Contraction.
Yeah, but what's physiologically happening there? And this is
It's on the sodium.
yeah, we're talking about which electrolytes are being exchanged.
Sodium, potassium exchange.
Okay, so you have sodium and potassium that are being exchanged. So here the sodium is coming in and the potassium is coming out, and that causes the atria to contract. So that pumps blood where? Where does the blood go when the atria contract? Okay, it goes into the ventricles. Now the PR interval, remember we said this is the time from the initiation of the electrical activity. What is this line between the this PR interval, what does that represent?
Contraction of both left and right atria?
Well, not yet. Okay, this is where the it's traveling across the heart or through the heart to the AV node, right? This is the SA node firing. It's traveling over here to the AV node. When it reaches the AV node, then we get the QRS complex. So now we have the ventricles contracting. Okay? But this time interval is important because if you have poor perfusion or if you've had injury to the heart, this is going to be extended. Okay? These time intervals are very important. The reason why they even monitor them is because if you do have problems with the heart, you're going to see changes in that. Now, the QRS complex, we've already said that's ventricular contraction. The Q wave you don't normally see. It's not that prominent. Okay? If you start seeing Q waves, then that means that you have some injury to the myocardium, either ischemia or you're starting to, early stages of infarct. Okay. The R wave, this is maximum, this is the peak of electrical activity. So your maximum sodium is in there. And then when we get down here to what's happening in the ST segment? Depolarization? Or you mean repolarization?
It starts.
Okay, yeah, we've just concluded the maximum electrical activity, so now we're pumping out the sodium and replacing it with potassium. Okay, so that's what's happening here. And again, if you have poor perfusion, this is going to be extended. Or if you have ischemia, you're going to see a depressed ST segment. Now, by definition, we normally say if this is depressed more than 3 millimeters, we've got a problem. And one of the things that you, as the technologist, have to be aware of is when you're doing the stress testing, if you start seeing ST depression, you better plan on stopping the study real soon. Okay? But ST is where we're repolarizing the muscle for the next contraction. So what does the T wave represent?
Visualization of ventricle.
Yeah, this is when we're done. So this is the end of the repolarization. So now it's ready for the next, cycle. Okay. So again, in my handout, I gave you a list of time intervals for those. Let me see where I put it at here. Okay. In the handout that I gave you underneath it talks about the nerve conduction in the heart. So I'm not really concerned that you know what the millivoltage is or anything like that. Like I said, you guys have already had an EKG class, so they probably went over that with you. Okay, I know everybody remembers it, because I remember it, right? Okay. But anyway, so this is what we're talking about here. So this is the sodium-potassium exchange. And then in the AV system, we also now have another electrolyte, calcium. Okay. Calcium is thrown in there. Does anybody know why calcium is thrown into the AV node? Ashley, why is calcium a part of the AV node?
Don't know.
Mr. Andy? Okay, calcium takes longer to infuse, and this way it ensures that the ventricle has enough time to fill with blood. In other words, what happens is if the ventricle contracts too fast and it hasn't completely filled with blood, we don't have a very efficient heartbeat, do we? We have to pump the blood from the atria into the ventricle, but we have to give the ventricles enough time to fill. So by adding this third electrolyte, the calcium, it slows down the electrical conductivity to where the ventricle takes a little bit longer before it contracts. Okay. Does that make sense? Your body is physiologically slowing itself down so that it makes sure that there's something in the chamber to pump. Okay. Remember, that's one of the problems we have with ventricular tachycardia. If the heart is pumping too fast and it doesn't have enough time to fill the left ventricle with blood, then when you contract, there's nothing to pump out.
So there's high calcium that speeds up. There in the calcium blockers.
Right.
Calcium channel blockers.
Yes, sir. Now you understand the whole mechanism behind this thing. Okay? So that it's a deliberate thing done by your body to make sure that there's adequate time. But the thing is that, remember, the EKG is basically showing you the direction and timing of electrical activity in the heart. Sometimes, well, I should say all the time, whenever we do a stress test, either pharmacologic or on the treadmill type stress test, we typically do what we call a three-dimensional EKG. That's basically what a 12 lead is. It's showing you the 360-degree, three-dimensional electrical activity of the heart. Okay. Did you guys cover this when you were in? So you remember what AV1 is and AV2 and all that good stuff?
We want to lead to the most.
Well, I mean, typically for us in nuclear medicine, when we're doing MUGA studies or doing any type of gated acquisition, all we typically use is the 3-lead. Right arm, left arm, and leg, right? Okay. The 12-lead is, the three-dimensional. It's a little bit more involved, but in this handout that I sent you on chapter 24, it'll give you a reminder of what the 12 leads are. You're not going to be seeing much of that on your board exams, but you do have to understand what you're actually looking at. Okay? But the thing here, okay, now this one, this is one of the leads here, the B1. But basically, this is what they call normal sinus rhythm. So if I said that you had normal sinus rhythm, what would your heart rate be approximately?
80.
60 to 100.
Yeah, probably more for adults, probably 60 to 80. For children and infants, a little bit higher. But basically what you're looking at, okay, you want to make sure that you see all of the, this is your QRS, but because you're looking at it from a different angle on a 12 lead, it has a negative deflection. Normally when you see a positive deflection, it means that the electrical activity is traveling towards the surface of the chest. When you see a negative, it means that it's traveling away from the chest. Okay? So in this case here, you're just kind of looking at it. This isn't one of your typical leads that you would be using. But basically everything is there. You have the PQRS, and here's the here's the T wave over here, and then all the other stuff is there. So 62 beats per minute, so that's good. Now here's a good example of bradycardia. Okay, when they say sinus bradycardia, what does that mean? Huh? What does the sinus part mean?
It's coming from the SC.
That's,
Normal impulse from the SC node.
okay, yeah, basically all of your components are there. You still have the PQRST, so all of your components are there, it's just that it's very slow. What kind of things would you be concerned about with bradycardia? What's happening in the heart?
Body bleeding. It takes longer to fill and it's beating slower than.
So you could have a patient that's going into shock. Normally a low heart rate like this, you could also have, remember, vasovagal problems, vagus nerve stimulation, okay, shock, things like that. So this isn't good. What would you recommend in a situation like this? What if we had a vagal response here? What drug would be administered to the patient to overcome a vagal response? Okay, atropine, very good. Yeah, well, atropine. Now you wouldn't give like an epinephrine or something like that. It really wouldn't be effective in a patient that has vagus nerve stimulation. So you give atropine, and if that didn't work, then you would start looking at like dopamine to raise the blood pressure and epinephrine to increase the heart rate. Fluids, because they may be going into shock. But again, sinus bradycardia just means that it's lower than normal, but everything is still there. What about sinus tachycardia? What does that mean?
Heart beat fast.
Okay. Notice the heart rate is 116 beats per minute. I don't know if did they show you guys how to calculate what heart rates are?
Yeah,
Yeah, you measure I think, I'm trying to remember the way that you do it. It's you find one of the major lines down here and
Counting the R's between certain.
counting the boxes between the R to R intervals.
So that's like a R to R of 500 milliseconds.
Yeah. So the thing here is then, okay, so in this case here, we would normally expect this on a patient that we're either exercising on a treadmill, or what other drug would I be giving the patient that would cause an increase in heart rate? Does persantine or adenosine or lexiscan do this? Huh?
Just dilate coronary arteries or.
Okay, dobutamine is the one I was looking for. If we were giving any like the A1 or A2 receptor medications, all of the adenosine, lexiscan, that's actually going to cause a decrease in the heart rate, correct? In fact, how do I know that my drug is working? Let's say that my patient comes in, they have a heart rate of 80 beats per minute and a blood pressure of 120/80. So I started infusing the adenosine. How do I know when it's working? When should I inject my radiopharmaceutical? What should happen to the heart rate if my adenosine is working properly?
The blood pressure will drop because the expansion of the blood vessels throughout the body, the A1 and A2.
Okay, so how much should my blood pressure go down to tell me that it's working? What would my blood pressure be?
Maybe 10 points.
Maybe?
I don't know this.
You guys have been doing stress testing for,
the adenosine.
well, or even lexiscan, it doesn't matter. If you're using any of those for persantine,
Well, that's right. So 10 millimeters of mercury, if it drops, or the
Okay.
heart rate will go up 10 beats a minute.
yeah, the blood pressure should go down by 10 and the heart rate should go up by 10. That's how you know that it's working. Okay, you guys, I mean, you may be on your own. You may be at some imaging center and the doctor's gonna say, okay, I'm gonna be over there in an hour, so I want you to do this patient before I get there, which probably isn't a good idea. You know, I mean, if you have a problem, the patient has a myocardial infarction, that's not a good idea. But the thing is, you need to know what these drugs do and when they're actually causing the effect that you want. Okay, so sinus tachycardia, we would expect, we still see the PQRST, so everything is good there. Okay? Okay, you guys had EKG training, so what's going on here? What is that? 3-1 flutter. What's fluttering?
Is that fibrillation?
Huh?
Your heart is
The heart, yeah, but what part of the heart?
Atrium.
Okay, yeah, because your ventricles are still working fairly normally. Here's your QPQ, or here's your QRS pattern here, so that's okay. Yeah, that's atrial flutter. Okay, we also call that a sawtooth.
Is that also with the stemming?
Huh?
I'm sorry, is that also with the stemming? The third one?
Which one?
Yeah,
No. But this is important because this can create defects, okay, on your scans. Okay, let's take a look over here. Okay, PVC, what does that mean? Okay, but what does it mean? We know it's a preventricular contraction, so what's going on with the heart and how's that going to be a problem for us?
A ventricle fired off an extra bead.
Yeah, normally we see a PVC after a T wave. Remember, the T wave is supposed to be when the ventricle has repolarized, but it's firing out of sequence, right? And how would the patient experience a PVC? Or what would the patient say that they're feeling?
Their heart skips a beat.
Yeah, their heart's skipping a beat. If you were to feel, would there be a pulse if they had a PVC? Huh? If we just had a T wave, which means that the ventricles are repolarized, and all of a sudden we have it discharge, just because. Okay, does the ventricle have any blood in it at this point?
No.
So if there's no blood in it, are you going to have a pulse? No. Okay, because we didn't have the P wave to pump blood into the ventricle, if this thing fires, the patient's going to feel like their heart's skipping a beat, but you're not going to feel a pulse when you're palpating an artery somewhere. Okay? Now, the bad thing is when you start getting runs of PVCs, because a lot of time that's usually a sign before they go into ventricular fibrillation or just cardiac fibrillation. Okay? So when you start having runs of them together, that's usually dangerous. But what's also bad about these is that this really kind of messes up your gating. Okay? Because normally your computer has calculated the time interval between 10 heartbeats, or 10 R to R intervals, and when you throw something like this in here, that kind of, normally this beat would be rejected. But if you start having a bunch of runs of these things, then it kind of, you'll see a whole bunch of your heart rates being rejected on your, during your acquisition. So anyway, so a couplet is when you have two PVCs together, a triplet, 3 together. When you start getting triplets, this is a really bad sign. Okay. And then sometimes you'll see it, if you have it, if it's constantly going on like that, you'll see it what they call bigeminy. So this is a pattern that you might want to recognize down here. So here you have one, the PVC is occurring at a regular interval here. Okay? So, and it's occurring in regular intervals like that, and especially like every other heartbeat, then they call that by Gemini. I was thinking of Gemini cricket. Okay, now, the reason we're getting into some other things here, what is this one up here, guys?
Um,
Is that an AFib or
Ventricular tachycardia.
It's important, okay, you're doing a patient, and all of a sudden you start seeing an EKG pattern like this.
VTAC.
Ashley? No? Okay, this is VTAC, ventricular tachycardia. You notice that you don't see the P wave anymore. Okay, all you're getting are QRS, QRS, QRS. And the problem is, what's the problem with this?
there's no blood being circulated.
There's no blood being circulated. The patient would probably still be conscious. If you tried to feel a pulse, you probably wouldn't feel one. And it's only a matter of time. This one, and then what's this one down here?
Ventricular fibrillation.
Okay, ventricular fibrillation. This may even be part of the same patient, I don't know, but usually this, ventricular tachycardia, will eventually lead to this, ventricular fibrillation. And then ventricular fibrillation leads to this, asystole, okay, or a straight line. Okay, you see a little bit of electrical activity once in a while. But these two are very important because, of course, they're life-threatening situations, but also, why are they important to you as the technologist? Well, it probably would be, you may or may not be calling a code blue, but probably, yeah, for this. But these are the only two conditions that we actually shock a patient. So these are where you would be actually defibrillating a patient. That's why you have to recognize them. Of course, if you also have a mean, nasty patient with an attitude, you can also shock them for that too. A little patient attitude adjustment. Okay? But yeah, that's something that you need to remember, is that whenever we have ventricular tachycardia or ventricular fibrillation, those are the two shockable conditions for defibrillators. Okay? Some other things that we will mention here. Okay, what do we have here down at the bottom?
Bundle branch block.
The ventricle.
Okay, bundle branch block, is it a left or a right bundle branch block? Okay, remember, let's kind of go back here for a minute, okay? Oh, let's see, where's the heart anatomy?